So at personalized medicine, I mean, cancer doctors are now using patient genetic code to determine the most effective therapies for their care. How has this transformational approach changed your work?
Yeah, we always knew the genes were the most important aspect, right? And we're still light years away from where we should be. But, when I first started in medicine, terminologies like the cancer patient or the breast cancer patient, well, that's not exactly right, because when you state it that way, it's letting the cancer define you. You're a person, you're a patient with cancer. And it's just one word, but it changes the whole meaning.
Yeah.
One of the other things is, they failed therapy. They failed chemotherapy. No, they didn't fail anything. Chemotherapy failed that person. Okay? We didn't have the drugs or the technology smart enough to beat it. So personalization of medicine, yes, we are finally getting smarter. We can now see, and my specialty is lung cancer, if I have 3 people in front of me who have lung cancer, just because they all look the same under a microscope, that's like saying there are 3 people in here who have brown hair. They must all be the same. And that is very naive. You'll laugh when I say that, but that's how we treated cancers before. They all look the same under a microscope, so they must be the same. No. They have different genetic origins. They have different patterns in how they spread. And so that's why getting to the genes is so important, because now we're trying to interrogate the brains of those bad cells and figure out what is pushing them to become harmful to you, as opposed to just coexisting or being latent. So this is why it's so important. That's why we now have markers that we can test with cancer in the clinic, and it's so important.
Ed, why is diversity in clinical trials a real passion of yours?
I never understood why there were so many eligibility criteria. I mentioned this yesterday. 37 is the median number. Now, when that drug gets approved, does your doctor go through 37 eligibility criteria in your office to make sure that you can take that? Absolutely not. So, and I get why that was. Why was it? Because our therapies in the past were only incrementally better. So in order to measure statistically an improvement that was enough to pass an FDA or regulatory hurdle, you needed to really control your population, right? But we don't want those drugs anymore. We don't want those incremental drugs. We want great drugs that make a big difference in people. So the bar needs to be reset, okay? And we need to reset it to include everyone. So it's been our passion and one of my missions to reduce those eligibility criteria. And I can tell you we've been doing efforts, going 7 years now, and that's what I want to see, because we know medicine moves slow in some areas and really rapid in others. This is an area we've just got to fight that standardization and be transformative.